enter full screen mode. Okay. So let's begin. This is going to be more of a qualitative talk than it is a rigorous evaluation of RCTs and systematic reviews and meta-analyses, because of course we simply don't have that much when it comes to COVID-19, although we're starting to see some systematic review. So what are we going to look at here? I think that this is a talk. I've certainly given talks before on COVID-19, likely in large part because I'd written 3 different statements on it for the Canadian Pediatric, because this is also going to look at the impact on families, and we're going to look also at the impact on NICUs and look at it from a global perspective. And what better forum to talk about it than in a forum like this, where we have people from, I think, all over the world tuning in, so we can see what the current state is of thinking across the globe. We're also going to look at staffing and impacts that COVID-19 has had on that. And then we're also going to look at time and presentations, which is looking at the impact on the baby, but also looking on adjustments that families have had to make, and what strategies families are looking to deal with COVID-19. So I have nothing to disclose. I've received no sponsorship or financial compensation for the talk, and no conflicts of interest. So let's begin with trying to answer 3 questions. Pandemic in particular, in the early stages in March through June of 2020, what we saw were lots of interesting reports of remarkable reductions in preterm birth during the pandemic. So we're going to look and see globally what that local example here, because I happen to know what happened here in Winnipeg, Manitoba, Canada. We're going to look at staffing, and we're also going to look at what about symptomatic newborns, and then moreover, what about the effect then on NICUs? Because if you certainly saw a lot of symptomatic newborns, you'd expect many admissions. So probably the paper that got the most attention in the beginning was the Danish report by Hederman. And this publication certainly looked at impacts pre-lockdown. So they looked at 2015 to 2019, and if you look at the figure on the right, you'll see in the top left-hand corner, this is pre-lockdown, showing the blue bar is 2015 to 19, the red bar is 2020. This is again prior to lockdown, and you can see that there was a bit of a difference in very preterm births, but as far as the extreme prems, not a huge difference in the percent that they were seeing. But when you look at the bottom 2 graphs, what you see is, again, not much difference in this case, not much different during lockdown comparing 2 periods for very preterm births. But when you look at the extreme premies, so the ones, let's say, in that 22 to 20 reduction, they quoted about a 90% reduction in the incidence of preterm birth, and this certainly got a lot of people's attention. The Irish published their experience. They looked at two different time periods. They looked at what their average was from 2001 till 2020. They looked at the average number of very low birth weight infants born per 1,000 and extremely low birth weight infants per 1,000. And what they found was that the average, and it was 2.86 for extremely low birth weight on a yearly basis. You can see the precipitous fall off down to 1/4. So they experienced, for the very low birth weights, about a 75% reduction in 2020 during the January to April period, and they went to 0 for extremely low birth weight infants. So these 2 studies together created a lot of questions about a slide from this paper from Ireland, because it really tries to capture a bunch of different factors, both positive in green and negative in red, that could have influenced the impact of stress and socio and environmental and behavioral modifiers in pregnancy. So, for example, much has been speculated about reductions in traffic, motor vehicle traffic, and reductions in air pollution. I didn't include it here, but the space before and after the pandemic showing the atmosphere was much clearer. So ambient air pollution, the worse it is, the expectation is that could lead to more preterm birth, whereas lower levels of air pollution would favor less preterm birth. Something that has been very interesting is the concept of stress and the effect on preterm birth. You know, I will put this out there, that when we look at that are very concerned about the messaging that could come out of the pandemic, being that we could set back women's movement about 100 to 150 years by suggesting that women who stayed home, avoided traffic, avoid stress, avoid work, were at greater chance of having a pregnancy that did not lead to preterm birth. We do have to be very careful about this message, you know, and I think that much research will need to be done looking at truly what has the impact been of these different factors, and which one the impact of impact of having less preterm birth. One thing that also came out of this study was, as of 2018 in Ireland, you were able to have an abortion, and so the incidence of stillbirths and pregnancy termination were not found to be increased during this time, so we can't blame it on that. When you look at the US experience, though, it tells a very different story. This paper by Hanley is recent, from January 2020, looking at preterm births, and what they found was the unadjusted cohort of just looking at preterm birth from all of these different pregnancies, 5907 versus 3007, found the incidence of preterm birth was not changed. Something, though, that is a hot topic, and I've highlighted there for you, is, and this is a talk unto itself, is much has been written right now or discussed in the US in particular about racial inequity and disparities in health, was that in the pandemic epoch, if you were a non-Hispanic white person, there was a significant reduction in the rate of preterm birth for that group. So, you know, one can, you know, do a lot of speculation as to what this means, but it could mean that non-Hispanic whites experienced less stress during the pandemic for all the reasons that I went through with the cohort in Ireland, whereas those that are not white experienced the same amount of stress preterm birth before the pandemic and during the pandemic. So this is something that, again, more research will be done on. Again, looking at the question of, do stillbirths rise? Can you explain the difference in outcomes here by the rate of stillbirth? And this is a study out of the UK by Stowe, also published in January of 2021. Again, looking at that impact during the pandemic and finding that there really, at least in Britain, was not a significant change in the rate of stillbirth during this time. I did tell you that I would fill you in on what things happened here in Winnipeg. This is unpublished data, but we've looked at our pandemic. We saw a dramatic reduction in the anticipated number of preterm births that we were seeing in terms of extremely preterm birth or extremely low birth weight infants. Interestingly, when we looked at calendar 2020, now that we've jumped to 2021, calendar 2020 compared to calendar 2019, we found 49 births under 29 weeks in the period of 2019, and during 2020 we had 50. So we also know our stillbirth rate had not increased. So it's important that when we look at these reports, longer epochs, but we need to be careful looking at small windows because a lot of centers were reporting drops in preterm birth, but I'd be curious if they looked year over year what they found. So let's jump to looking at COVID-19 in newborns and examine the risks of vertical transmission, the risk of admission to NICU, and what symptoms one can anticipate in the neonate. So when we're looking at risks of vertical transmission, I know Daniel DeLuca is presenting or has presented today, and he's a documented case of vertical transmission. So we know it does happen, but rather than present to you copious numbers of studies, I chose to present this one, which was a systematic review by Walker, looking at 666 babies. And essentially what it showed was the risk of vertical transmission is low. The rate of C-sections is about twice that of vaginal routes, but we also need to remember that cesarean sections, at least in the initial stages of the pandemic, were being performed much more frequently, especially in China, based on the experience from MERS and SARS, leading to worse outcomes for neonates. They were electively delivering many of these women when they were symptomatic and as late preterms, and they were being done by cesarean sections. So do you need to have more cesarean sections? I don't know. I suspect not, but that is probably where that influence is coming from. One thing that I can share with you is, like many places across the world, there are registries now with many patients. The CAN COVID group is a Canadian registry, and this report is from just last month. And so far, we've considered potentially positive in keeping with vertical transmission. And this actually is very similar to the rate that I just presented to you in the previous slide. Interestingly, as I'll show you, something that has been very consistent across studies is the rate of prematurity is somewhere between about 12 to 15% in pregnancies affected by COVID. Nicely, Canadian data is showing that 66% others were breastfed. And when you look at NICU admission, and strangely, this is also very consistent, you'll see between 14 to 15% of babies, so about 1 in 8 babies or 1 in 7 babies are going to need admission to the NICU. So certainly not what I think we're expecting when you look at the initial stages of the pandemic. I think people expected a lot more admissions. What about where patients are going in the NICU? Now, this is what we do here, negative pressure room. Otherwise, we have the luxury of having single patient rooms, and we can use droplet contact precautions. For mothers that are suspect, that's more difficult because we tend to cohort infants together into one pod, which is based on the geographic layout of our unit. Easier to do when you have single patient rooms and pods. The problem there is, even with early testing, you may wind up with some babies who turn out not to be positive being cohorted into spaces where there are positive mothers. So then air exchanges per hour to ensure minimal risk to the infant and mother. What about features? What does the infant with COVID-19 look like? Well, many of them will be asymptomatic because about 85% do not get admitted to the NICU. But when you look at this study from November 2020, looking at 68 newborns who had confirmed COVID across 35 studies, I mentioned to you about anywhere between 12 to 15% will be born preterm, and that's what was found here. In this study, they found 38, but 1 in 10 babies are ventilated. So this, in spite of this being a condition that we believe does not cause a lot of morbidity in infants, certainly there are, of the infants that are admitted to the NICU, some will be ventilated. Is that due to COVID? Probably not, more likely due to them being preterm. What sort of symptoms? Symptomatic, but of those with symptoms, 3/4 will have respiratory difficulty. Of note, if the baby was term and that none of them needed respiratory support, which would fit with what I said just moments ago, that you're more likely, if you are delivered due to COVID or if mother has COVID, you're more likely to have a non-COVID related cause, such as RDS or TTN for your respiratory distress than you are to have respiratory distress from COVID. 2/3 will have symptoms or diarrhea. Interestingly, we don't often see cough in neonates, but we've certainly seen a case here, which we're going to be publishing, of a baby that presented with cough that actually had pneumonic infiltrates on x-ray. So about half will present with cough, half will present with diarrhea, and half with neurological symptoms. Now, what about staffing? This is an article in late November about the U.S. shortages in nursing and staffing related to COVID. Not surprisingly, when you look at a map of the U.S., which is on the right, you can see that some of the states that are hardest hit had the greatest shortages. Of interest, in terms of a tale of two countries, the hardest hit staffing short by population of their residents have developed COVID-19. I live directly above that brown state there in Manitoba, and we have not seen anywhere near the levels of COVID-19 that North Dakota has. So, I think studies also are going to be coming looking at strategies for prevention of COVID and how that may have influenced the staffing in different places. So there's no question you don't need a lot of data to know any places. Staffing is also affected due to policies that exist in your institution. So, for example, staff here with a suspicion of COVID must isolate for 14 days or until they get a negative test. If you have confirmed COVID-19, you must isolate for 14 days. More recently, with the pandemic spreading and many people having COVID-19 but being capable of work, COVID-19 wards with people who have COVID-19. So that is something that was done to mitigate the effect of reductions in staff. And then a third point which has come up in Canada has been what to do with essential workers. If you are a neonatologist or you're a nurse working in acute care, how do you deal with the need to provide staffing, even if COVID-19 is running rampant? At a provincial level, or in the US, you would consider that a state. At a state level, there might be regulations that require you not to work, which you can get around, but as I know at the Canadian national level, there were federal rules that came into effect that prevented me from having a worker who was perfectly well and we knew had a negative test for COVID. Even though they were known to be negative, they must isolate under quarantine for 14 days. So these are some of the challenges that we have with staffing. And I'm sure if I was to speak to many of you from across the globe, you would tell me you've got similar issues. A Canadian study published in April of 2020 found 80%, so 4 out of every 5 Canadians that were surveyed found that their mental health had deteriorated during COVID. A study in nutrients looking at the nutritional adequacy of Canadians found that, interesting, you might ask why I'm presenting a nutrition study, it was because of the other things that they looked at, which was stress level. Even children who are aware, as my 4-year-old, asked just the other day when she heard somebody was sick, she said, "Is it COVID?" And I was struck that a 4-year-old even knew what COVID was. But almost 1 in 10 children experience very significant levels of stress from COVID. Financial stress is not surprising, but what is surprising is even over the next 6 months, about 1 in 20 Canadians are expecting still to have financial distress. And what the dietary choices Canadians were making were also affected by COVID because people were not wanting to go out and shop as much. And so because they weren't shopping, they were going for lower quality foods that they could keep in freezers for a longer time. So there is a lot of impact out of these 254 surveyed patients or people. Just glossing over this quickly, this was also part of the study looking at some of the things that are impacting on the stress levels. A couple highlights. Parents were finding that there were tantrums and fightings between siblings that were increasing. They were wondering, how do you plan ahead and make trips to the grocery store? This might not seem like that big an issue, but if you have children that you can't leave alone, and you also don't want to take them to the grocery store to be exposed, and you also are under provincial or state limits as to how many people that can be in your home, how do you arrange for childcare? Lots of stress. And as I mentioned, meal planning, of course, is also a consideration. Early stages of the of COVID-19, you wind up with having to deal with stress from misinformation. We knew from a study by Breslin looking at the New York outbreaks that was published back in May, out of 43 mothers with COVID-19 infection, which was small at the time, but what this found was that about a third of women presenting to the New York hospitals were found to be asymptomatic. Based on this, a decision was made to screen all pregnant women coming to the labor floor. And what we discovered within 24 hours of putting this screening protocol into effect was declining, had to do with social media, post to Twitter, post to Facebook, post to TikTok, to LinkedIn, that in Manitoba, if you get tested and you test positive, your baby will be taken away from you. That was not the truth. We would never take away the babies. We would cohort the baby with the mother. But simply because of misinformation, stress levels in our communities rose dramatically. So this stresses to me the importance of connecting with families and discovering what information is out there. Moving on to breastfeeding support. This is from market research back in August of 2020 from US, UK, France, and Germany, that even